Hello, welcome to the introductory video on a framework for decision-making in clinical practice. When a recommendation is made using this framework, letter grades are assigned to each recommendation statement. These grades are based upon the strength of the evidence as well as the harms and benefits of a specific preventive service. The grades are as follows. A. The guideline panel recommends the service. There is a high certainty that the net benefit is substantial. B. The guideline panel recommends the service. There is high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. C. The guideline panel recommends selectively offering or providing the service to individual patients based upon professional judgment and patient preferences. There is at least moderate certainty that the net benefit is small. D. The guideline panel recommends against the service. There is moderate or high certainty that the service has no net benefit or that the harms outweigh the benefits. And finally, insufficient evidence. The guideline panel concludes that the current evidence is insufficient to assess the balance of the benefits and harms of the service. Evidence is lacking, of poor quality, or conflicting, and the balance of benefits and harms cannot be determined. Insufficient evidence can cause the grade given to a recommendation statement to be lowered. Insufficient evidence is evidence that is considered to be lacking, of poor quality, conflicting, or the balance of benefits and harms cannot be determined. There are 4 domains for clinical practice that are important when making a recommendation. The first domain is potential preventable burden of suffering from the condition. Provision of an intervention designed for a serious condition might be viewed more favorably than provision of a service designed to prevent a condition that does not cause as much suffering. For example, we may view more favorably on dementia than on the rash. The burden of suffering is subjective and involves judgment. In clinical settings, it should be informed by the patient values and concerns. The second domain is the potential harm of the intervention. An intervention with a large potential for harm might be viewed less favorably than an intervention with a small potential for harm. The assessment of the potential harms is also subjective. The third domain is cost. Not just monetary cost, but opportunity cost. In particular, the amount of time a provider spends to provide the service, the amount of time the patient spends to partake of it, and the benefits that might derive from alternative uses of the time or money for patients, clinicians, or systems. The fourth domain is current practice. This domain was chosen because it is important to clinicians for at least 2 reasons. Clinicians justifiably fear that not doing something that is done on a widespread basis in the community may lead to litigation. The consequences of not providing a service that is neither widely available nor widely used are less serious than not providing a service accepted by the medical profession and thus expected by patients. Secondly, ingrained care practices are difficult to change, and efforts should preferentially be directed to changing those practices for which the evidence to support change is compelling. Together, the domains all involve consideration of the potential consequences for patients, clinicians, and systems of providing or not providing a service. Now let's take a moment to look at the application of the 4 domains. A lung cancer screening by using a CT scan. As you can see, the 4 domains are found on the left-hand side of the table: potential preventable burden, potential harms, costs, and current practice. Information regarding these domains can be found on the right-hand side of the table. Information varies from survival rates to costs and to current screening practices. That concludes our video. Thank you very much.